Welcome everyone to the Center for Global Development. I'm Amanda Glassman. I'm a senior fellow and the chief operating officer here, and I work also on global health. We're really pleased to co-host the launch of the Global Financing Facility's first results report together with the GFF and the World Bank. So at the Center for Global Development, we focus on how to enhance the value for money of scarce global health funding. We look at how the way we raise, allocate, and spend, and how the way we measure results and establish accountability helps or hurts with effectiveness on healthcare coverage and health outcomes. And we try and work with the major players in this field on ways to do that better. We focus on these issues because the way that external money has been deployed in global health is far from optimal. We've had an enormous amount of success, but sometimes we do it in ways that don't achieve the best results. We're doing some recent work on procurement efficiency, for example, and in one low-income country, and this is a typical case, I'm afraid, we're seeing 12 sources of external funding for a set of 20 essential medicines being procured through 11 different procurement agencies with the predictable results in terms of availability. And, so I think the Global Financing Facility is in many ways an amazing answer to these really ubiquitous challenges that we face in the field. It's squarely focused on these issues. And it's already showing tangible results on financial leverage. And if you take a look at their results report, I'm sure Mariam will tell you this as well. But for every dollar of the GFF, $7 in IDA or IBRD government financing. That's a very significant leverage ratio. They also focus on alignment between health needs and funding. They give us two examples from DRC and Cameroon, showing that more money should go where needs are greatest, and therefore where expenses are greatest. That's a very encouraging and important feature. And finally, we're seeing evidence of increases in coverage in the near term, and they're also learning lessons about what is and isn't working in the places where basic reproductive, maternal, newborn, child, adolescent health and nutrition has long gone underprovided. It's a mouthful, RMNCAH-N, but it's a modest investment, and it's really at the heart of primary health care. So I'm really excited to have them here. Getting these issues is really vital, given that countries are growing economically and will transition from different sources of global health aid, including IDA, and some face significant fiscal consequences in the next 5 years. My colleague Rachel Silverman has a new paper out, and it finds that the very focused countries of GFF, like Ethiopia, Nigeria, Cameroon, DRC, Mozambique, face the loss of resources in the near term equivalent to between 16 or more than 100% of current public spending on health. And that means whatever we want to do right now in terms of influencing priorities for primary health care, this is the moment, and I would argue that GFF is the way to get that done. So we'll have first Dr. Mariam Clayson, who's director of the Global Financing Facility, to describe the work of the GFF. And then we'll have a wonderful panel, including His Excellency, Mr. Sharif Mumina Sai, Dr. Ann Stars, president of the Guttmacher Institute, and Dr. Sean Baker, the director of nutrition for the Bill and Melinda Gates Foundation. And we'll discuss the results as well as the upcoming GFF replenishment. So without further ado, Mariam, thank you very much.
Thank you for that lovely introduction, Amanda, and thank you to all of you who have come out in the rainy late July part of the summer to join us here. It's really fantastic, so thank you for that. And let me also say a thank you to the panelists that we have here, because they are very special. And I want to mention in what way they are special. Sean Baker was one of the first bold directors at the Bill and Melinda Gates Foundation to actually think it was worth investing in the GFF before we had proof of concept. So having those early investors that want to take risks, Sean, we really appreciate that. Now I know that Sean really cares about the N in the RMNCH and N. I know that Anne, who is here with us, Anne Stars, who by the way is also special because you've always argued way back for the continuum, the RM, NCH, and N, that somehow these things are all interrelated, but I know you probably will argue for more letters into this alphabet list, the S in the beginning. Having with us Sheriff Sai from the President's Office in Burkina Faso is also extremely special, not only because you're hosting the GFF's replenishment, but also for the leadership you and the President has shown in that part of the world and globally to articulate the UHC vision. So we're very happy about that. And Amanda, you were early champion, pathfinder for thinking about outcome-driven investments, performance-based. And last time I was here, we discussed the Mesoamerica, who I think in some ways have some similar elements that you really are trying to move countries' systems forward towards health systems approach. So we are very, very happy for all of you who are here and joining us online. So here we are after 3 years, and some still are asking, so why was the GFF created at the end of the SDG and the beginning of the, end of the MDG era and the beginning of the SDG era? I think although we recognized that we had some quite impressive progress in the area of child survival and other important outcomes, still we had an unfinished agenda. Still countries were lagging behind on maternal, newborn, child and adolescent survival, health and nutrition. So we had a huge agenda going forward, and I want to remind you that even a few months ago, we are 3 years into the SDG era, we still have to double down to actually achieve those SDGs. We have to double the rate of reduction of maternal mortality to reach the goal. So we have a huge and important agenda. At the same time, I think you all know that the overseas development aids gradually increased over the past decades to reach a plateau. And we don't expect that we will have that significant increase in overseas development aids that can help us reach these targets. So we have to think differently about financing. We have to look at how we can use leveraging, how we can use different sources, how we can really support countries to get support, financial support behind their priorities. So that's what the GFF was set up to do. So when we say that the GFF is catalytic, what do we mean by the GFF partnership and the trust fund resources that the GFF have? What do we mean by catalytic? We mean that the GFF supports countries first and foremost to reduce inefficiencies, huge inefficiencies. So how can we support the focus and the investments on the highest impact interventions, the most efficient service delivery modalities, and the key systems bottleneck constraints that have to be overcome to reach the outcomes? So that's why you hear so much about the country investment case, because that's a very challenging process for countries to prioritize. And you need to prioritize not just keeping in mind the burden of diseases and conditions, but who is it that's suffering, adding an equity dimension to it. So the second thing countries do is really mobilizing domestic resources. That's the talk of the town these days in all capitals. So how are we doing that? How much progress have we done already? And I want you to know that any country who joins the GFF signs up to work on domestic resource mobilization, raising revenues, allocate more efficiently, and really put their own domestic resources behind it. At the basic, protect your budget, and even better, increase it. Thirdly, there are links to IDA and IBRD. There were some bold statements at the launch of the GFF that somehow we would link $1 in the GFF Trust Fund with $4 of concessional financing. And the good news, as Amanda says, is that we are now at a linkage between 1 to 7. That's huge, as you can imagine. For countries, it means scale, but it also means it's their money. And how that's used. Thirdly, or fourthly, how do we align all our bilateral partners who are already in countries, all doing incredible important technical and financial support for countries. How can we line the bilateral, multilateral partner to actually support one investment case, the country's investment case, and reduce inefficiencies, reduce duplications, get more synergy for the money invested. And finally, crowd in private sector money. And there you all know the domestic resources and in particular private sector money far larger envelopes of money available to countries than we can ever get from ODA, development assistance alone. So that's what GFF sets out to do. First of all, countries lead these efforts. We try to empower countries. We empower Minister of Health to have that conversation with Ministers of Finance and with partners. And you see in red the first countries that joined the GFF, the first 16 countries, then you see another 11 who joined in the past year. And of course, what we're trying to do is, as many of you know, expand to the 50 countries. Those are the countries in blue, in darker shade, who have not yet become part of the GFF, but where we have demand for support to join this partnership. So where are we now? Everybody has asked us for the past, I would say, almost 2 years. So tell us what's happening in countries. We understand your model. That seems great, but what's actually happening in countries? So you will find that our first results report focuses on a few in-depth look at what actually happens in countries. It's stories around countries' progress and challenges and what they still have to work on. And then you will find for the first time a profile for each country, which of course is work in progress from all the first 16 countries. Some of the highlights, what we set out to do was to help countries identify, as I said, priority investments, start to accelerate progress to its outcomes, identify their priority health finance reforms across, and that's happening across all GFF countries. And clearly that's happening in partnership with others who work both on programming and financing. Getting more results from existing resources and increased financing was another thing we set out to do. We have, as of to date, with 452 million in GFF Trust Fund, linked that to 3.3 billion in IBRD financing. Happy to talk more about what that means, those linkages. And aligned, as of today, 15 bilateral donors are partnering at the country level through different kinds of modalities. Very important country partnerships. I would say there are about at least 3 bilateral donors in 10 of the first 16 countries. And then strengthening systems to track progress, learn, and course correct. And that's, of course, why we do M&E and monitoring, is for countries to have data to identify gaps, course correct, and move forward. We're doing resource mapping, supporting countries to actually map out all the resources coming into the country for RMN, CH, and N. And to date, we are up to 12 countries where you will see resource mapping. The one core public health function that's unlikely to be prioritized in any prioritization process is civil registration and vital statistics. So that's something we explicitly focus on in all the countries. And to date, we have 7 countries that are implementing CRVS and 2 more ready to go. So what are key results? What we care about is actually whether or not we are improving the quality of care, access to care, driving coverage, trying to bend the curve on outcomes. You will see a few studies. One is Tanzania. I'm just flagging the fact that more people, families, mothers, newborn children are actually accessing outpatient services, that we are increasing the high performance facilities, and by that we mean facilities in Tanzania are rated against a 5-star rating system, and we have countries that have gone from districts gone from 1 to 22% of their health facility rated with 3 stars. So the fact that you can use a rating system not just to rank, but also incentivize and mobilize and identify the high and low performance is really critical to our way of operating. In DRC, as Amanda said, it's pretty amazing that a country facing so many challenges, by becoming in charge and having what they call a compact unique, getting all partners to try to buy into one compact, an agreement around the core set of indicators and results, in 14 provinces where they are doing purchasing for performance, they have been able to increase the assisted deliveries with up to 14% compared to areas which does not have this model. Of course, increasing also coverage of vaccine. And that also makes it clear to all of you and us that the important role that other partners play, Gavi, Global Fund, and others who contribute to these efforts through their financing mechanisms. Cameroon is exciting because Cameroon, again, has decided to focus its resources in the north, where maternal mortality has increased and not decreased over the past years. So their whole effort is going to channel those resources into really purchasing for performance from public and private providers to deliver for pregnant women, children, newborn, and adolescents' health. So here again, you see the births attended by skilled providers increasing as high as 1% in a subset of facilities that had for the first time such a contract. On all these countries, Tanzania, DRC, and Cameroon, you will see more discussion in the reports. I'm not going to go into any detail about them, but I also want to flag our collaboration in Nigeria, which I think many of you also have been part of. So Nigeria has had the intentions to scale up a basic minimum package of services, again, across the reproductive, maternal, newborn, child, and adolescent health and nutrition agenda. And their challenge has been to mobilize domestic resources. And as you will see from this slide, increasing domestic resources for health has been our major focus, focusing on great efficiency and domestic resource mobilization, looking at the National Health Act, to which Nigeria's government is committed, and within that, the basic minimum package of health services, and making sure that something that was set up in Nigeria, the Basic Healthcare Provision Fund, got the money they needed to be able to put financing behind the basic package. And it was very exciting in May this year when there was a decision to Nigeria to actually invest its full 1% of the share towards this effort to scale up these services. The role that the GFF played among many partners was really to pilot that BHCPF, the Basic Health Care Provision Fund, and its outcome in a few states of Nigeria, 3 states. But the GFF also responded to an early request from the government to really purchase for performance in the fragile parts of Nigeria, in the northeastern part. And that's what's so important with our story from the first 3 years, is that we are seeing results in fragile areas. So let's look quickly at this short video clip for the kind of work we're doing on domestic resource mobilization.
Every year, more than 5 million women, children, and adolescents die from preventable conditions. That's equivalent to the population of Norway. While good progress has been made, a large annual health financing gap is leaving many millions of people behind. Governments have the opportunity to change this. The Global Financing Facility helps countries to transform how they invest in and finance health and nutrition of women, children, and adolescents. We help governments protect and increase the amount of money they budget for health and nutrition, and we ensure that those resources are used more efficiently, meaning governments get even more health for their money, more newborns and children survive, more girls stay in school, more women can work and provide for their families. With more opportunities, countries prosper, economies grow, and GDP increases. Government budgets grow, meaning even more resources for health and nutrition, and a truly sustainable way to finance it. Imagine a future where no one is left behind. We already are.
Thank you. Clearly, working on domestic resource mobilization, all of you who are working in that area know that's a medium, often long-term goal, but it's so important to start that conversation. So you may actually ask, what indeed does the GFF do in that landscape of partners? What we do is provide the technical assistance to help countries identify the best policy options to increase domestic health spending, work with partners, other partners, of course, the World Bank, but also WHO and others, on health finance strategies, so it really can help move the envelope. Fiscal space analysis, strengthen that dialogue with sectoral ministers and Minister of Finance. If you have a strong investment case, you are much better able to actually have a conversation with the Minister of Finance for domestic resource allocation and allocative efficiency. And financial incentives that we talked about. We even link disbursements indicators such as, in Mozambique, we will maintain our budget currently allocated for health and within health for women, children, and adolescents, and we intend to grow it. That's a very important way of trying to incentivize that we don't replace budget allocations with external aid flows and money. So a very important part of what we're trying to do. If we agree to buy down a loan, it is also then linked to domestic resources. So in Guatemala, where the government decided to actually, have a national stunting program and use IBRD financing, the GFF pays down the interest of that loan, but Guatemala also put in domestic resources. And those resources are then reinvested in indigenous peoples' RMNCH and needs. Cameroon, again, is one of those, as I mentioned, countries that are really focusing on allocative efficiency, increasing utilization of priority services, and strengthen their health systems. And what's interesting in the Cameroon scenario is what's there in bold at the bottom, that they have decided to double their commitment to financing of the health nutrition of women, children, and adolescents, and growing their health budget share from 8 to 20%. Based on efficiency gains. I'm not going to talk a lot about the monitoring, just to make very clear the reason why we support countries' monitoring of results is for them to use the data, to create that platform with stakeholders looking at data at the country level, link data on financing with programming, ask critical questions when you design your investment case and go forward around, are we really focusing on the right places in the countries that's lagging behind? Are the results that we want to aim for and the targets, do they even match the available resource envelope? Are we investing in affordable, cost-effective interventions? Do the committed investments that partner make actually match the gaps and the disbursements that we see? So very tough questions, and are the funds matching the needs, basically, very basic questions. So if we can have much more of that conversation going on country, that's what we are trying to do. Of course, we want to monitor progress towards what we are out to achieve in the long term. So there are some core indicators across all countries regarding maternal mortality ratio, their under 5 mortality, neonatal, adolescent birth rates, birth spacing, stunting and wasting indicators, and also what we are still working on, we don't yet have really great indicators on, is really looking at developmental indicators in young children. So just to say, we have a bottom-up approach. You will see these reports are about 16 countries where they are, but the idea is to support these countries going forward. And because we have now in each country a country profile that you see at the end, obviously a live document because it's about processes that change all the time. But this is to help you look at where is the investment case, what are the priorities in the investment case, what are the RMNCH and nutrition point estimates. Here we use data from Countdown and other partners, and those are things, as you know, that don't change on a continuous basis, but more on an annual basis. The health financing indicators, you will see, those of you who are finance experts, you will see that much more needs to be done in terms of getting a core set of really good, smart finance indicators, but this is a beginning to start to look at both financing going into health, into the overall into health, and then specifically towards RMNCH. But that is, again, very important work in progress. The geographic focus, are we where we should be? Are we mapping resources? So those countries who have a mapping of resources, you can see that. Again, that's an iterative process and improves as more transparency is achieved in countries. And then we have something that's self-monitor, the monitoring of the country-led process. It's self-monitor. Do you have an investment case? Do you engage civil society? Do you, all those critical steps that we think are essential for success? And by the way, this whole scorecard idea, including the process on GFF in countries, we really learned from civil society and some of their early scorecards for what's important to be able to report on. So you will see country profiles from 16 countries in the report, the first 16. What have we learned? We have learned that GFF can mobilize additional resources, can achieve rapid results in fragile areas, but we also have learned something more from feedback than from the report that you have in your hands. And that is that we have to improve communication and coordination at country level to really maximize the benefits from what everybody is providing at the country level. So the actions that we have taken going forward is really to ensure that we engage all stakeholders from the beginning. Private sector, civil society, bilaterals who've been in the countries for many years who know the sector well. We have appointed in this last round a liaison person now in each country in the government, not to depend on others, but actually a constant presence in the country, so you can always know who to go to. And then we are developing implementation guidelines, although we have a bottom-up approach to really help countries know where in the process is the country and where can you provide your technical inputs. Our vision, and I'll end with that, is really to contribute to eliminate preventable deaths among mothers, newborn, and children by 2030 and help countries get on a trajectory, accelerate progress on UHC, and to raise 2 billion over, we have an important milestone in November, and the purpose is to mobilize 2 billion for the next 5 years from 2018 to 23, so that we can support an additional 23 countries to learn from this first round of 16, now 26 countries, and move into a large-scale effect. So thank you, Amanda. I think I'll stop there. And just this gives you, I hope, an interest in reading more from the report itself. Thank you.
Great. So I'd like to invite our panelists to join us on the stage. And one of our panelists, Mr. Sharif Moumina Sai, who's the High Representative, the President of Burkina Faso, will be speaking in French. So if you do not have a translation headphone, can you please raise your hand and someone will bring them to you? So we'll just take a couple minutes to sort that out. I'm sorry that we are not more francophone. It's not good. Let me move this back too so that you can actually see us. And Anne, I'll give you this for your slides. All right, so does everyone have, let me just wait until everyone has their headphones. Okay, place them immediately on your heads. Let's test. Can you test? say a little something. Dire quelque chose. Cool.
Bonjour. Merci d'être là.
Okay. Okay, perfect. Okay, anyone else? Sean is perfectly fluent in French, so. Okay. Are we good with the headphones? Can I start?
That's a good sign, running out of headphones, I think.
And if you can, maybe share with someone sitting next to you. If we'll do a short summary of afterwards for those that are not able to hear. So let's start with you. Many thanks for joining us. We'll ask each of our panelists to give some short remarks, about 8 to 10 minutes, and then we'll have a discussion. First, a round of questions within ourselves, and then we'll go to you as the audience. So let's start first with you, and apologies that we do not all speak as good French as we should. So first, please start. Thank you.
Bien, merci.
Thank you.
D'abord, nous vous remercions.
Thank you,
Nous
first of
avoir
all,
associés au
for
lancement de ce rapport.
inviting us for the launching of this report.
C'est véritablement
And it is
un grand plaisir, un
really a
honneur pour
great
nous,
pleasure, an
parce
honor
que
for us,
mon pays, le
because
Burkina
my
Faso,
country, Burkina
est ravi
Faso,
de travailler
is
avec
delighted to work
le mécanisme de
with the
financement mondial.
global financing facility.
Parce que nous croyons
Because
qu'en
we
travaillant
believe
ensemble,
that by working
nous avons
together,
le pouvoir
we have the
de
power
révolutionner véritablement
not only to
le secteur de la
revolutionize
santé,
the
celle
health
de la
sector
nutrition
and
de
the
nos différentes
sector of
populations, et
nutrition for
surtout
our
travailler
peoples,
vers
but
une
also
couverture
to
de
work
santé
towards a
universelle.
universal
C'est
health
toute chose qui
coverage.
est
And this is
une priorité, en
a
tout cas,
priority
pour le président que je représente.
for our president.
Comme vous le savez certainement,
As you know,
puisque vous avez
probably, since
l'expérience
you
des 16
have
pays qui sont décrits
the
dans ce rapport,
experience of the
au
16
cours des 25 dernières
countries
années,
described in the report,
les
over
régions
the
du
last
Sahel,
25 years, the Sahel region, and Burkina Faso is included in this region, has made significant progress. But there's been a series of factors such as climate
les
change,
problèmes de sécurité,
security
les
issues,
déplacements, et la
population
faiblesse des
movement, and
infrastructures
the
ont
weakness
contribué à
of
une situation
infrastructure, and all
extrêmement
of
difficile
this has
où
contributed
de
to a very
nombreuses personnes
difficult situation
luttent
where
pour
many
pouvoir
people
accéder aux services
have
de santé
to
et de
struggle
nutrition
to
les plus
access the
élémentaires.
most basic health and nutrition
Ce qui, bien
services.
entendu, nous
This
donne un retard de
obviously
croissance
gives us
qui
stunting
est un
problems.
véritable problème,
And this is a
non
true
seulement pour les
problem,
millions
not only
d'enfants
for the millions
touchés
of
aujourd'hui,
children who are
mais aussi
affected
pour la
today, but
productivité
also
future
for the
et le
future
développement du capital
productivity
humain.
and the development of our human
Il a
capital.
été estimé
It has been estimated
que le produit intérieur brut
that the GDP
par habitant est aujourd'hui
per
inférieur
capita
de 9
is
à
now
10%,
lower from 9 to 10%
de façon générale en Afrique,
in,
à ce qu'il
generally
aurait été si le
speaking in
retard de
Africa
croissance
than what
avait
it would
été
have been
éliminé
if
lorsque
stunting
la
had
main-d'œuvre
been
actuelle était
eliminated
composée
at the
d'enfants.
time the current labor force was
Au Burkina
composed of
Faso, mon
children.
pays,
Burkina
la
Faso,
prévalence du
my
retard de croissance
country,
est en nette
in
baisse,
Burkina Faso, the
passant
prevalence of
de
stunting has
30%
fallen sharply
en
from
2015 à 21%
30.2% in 2015 to
2017.
21.2% in
Un autre point,
2017.
c'est la
There's
question de la
another
santé
issue, which
reproductive,
is reproductive
qui
health,
constitue aussi
and this
une
is
grande préoccupation.
another concern, great concern
Le
for
taux de
us.
fécondité parmi les adolescentes
Fertility rates among adolescent girls
et la forte prévalence des
and the
mariages
high
précoces
prevalence of early
et des
marriages
mariages d'enfants à travers le
and
Sahel
child marriages across the Sahel
ont d'énormes
have
conséquences.
enormous consequences.
Vous avez les
You
complications
have
qui sont liées
complications
à la grossesse et
linked
à
to
l'accouchement,
pregnancy and
qui
childbirth,
sont les principales
and these
causes de
are
décès
the main
des
causes
jeunes femmes
of
dans les
death
pays du Sahel.
for young women in the Sahel countries.
Au Burkina, par contre,
In
nous sommes
Burkina,
heureux des
we
progrès
are happy with the progress that
réalisés
we have made
en matière de
when it
planification
comes to
familiale
family planning
et d'autres défis.
and other
En
challenges.
effet,
In fact,
ce qui est une grande nouveauté pour nous,
and
la
this is
prévalence
very new for us,
contraceptive
contraceptive
est
prevalence
passée de
has
22% en
increased from
2015
22% in
à
2015 to
26% en
26%
2018.
in 2018.
Et c'est toutes choses qui font que nous pensons qu'une
So,
action coordonnée
We believe that
est
coordinated action is essential,
et le modèle
and the
GFF
GFF
est un
model
modèle idéal
is an
qui nous
ideal
permet de travailler
model
ensemble
which allows
pour
us
résoudre
to
certains
work
problèmes
together
auxquels
in
nous sommes
order to
confrontés.
solve some of our problems.
Pour notre part, l'une des premières mesures
One of the
prises
first steps taken
dès 2016 par le
in
président Compaoré
2016 by President Kabore
a consisté
was
à adopter la mesure
to
portant
adopt
gratuité
a measure
des soins
giving
profit des
free
enfants qui ont moins
care
de 5 ans,
to children who are less
femmes
than
enceintes,
5 years old, to pregnant women,
des accouchements et des
for
césariennes,
childbirth and
ainsi que pour le
C-sections,
dépistage du
and for
cancer
the screening
du sein
of
et
breast
de l'utérus.
and uterine cancer.
Cette démarche n'a pas été simple.
This was not easy,
mais cela démontre
but it
au moins
shows
que le gouvernement du
that
Burkina
the
Faso
government of Burkina
souhaite prendre des
Faso
mesures
wants to take measures
relativement rapides
fairly
vers une
quickly
couverture
to
sanitaire
reach
universelle.
universal health coverage.
Entre 2016 et
Between
2017,
2016 and
ce
2017,
sont plus de 100 millions de
more than
dollars
$100 million
que le budget de l'État a dépensé pour cette
were
mesure.
spent by the government out of
Et
its
chaque
budget
année,
for this measure.
c'est environ
And
50
every
millions de
year,
dollars que l'État va
$50 million
engager pour rendre cette
approximately
mesure
will be
durable.
allocated by the government to
Bien
make
entendu,
this measure
le
sustainable.
Burkina Faso
And
aura
obviously,
également besoin
Burkina Faso will
de
need
l'appui de la
the
communauté
support of the
internationale
international community
pour transformer la
in
promesse
order to turn
des objectifs de
the
développement
promise
durable
of the
en
Sustainable
action.
Development Goals into action.
Alors que nous nous mobilisons,
As Burkina Faso mobilizes
le
itself,
besoin de la communauté internationale avec le
the
secteur aussi
need
bien public que
for the
privé
help of the international
est
community
plus que
together
critique.
with the
Alors que nous savons tous
both the public
quelle
and
est la voie
private
pour
sectors, this
emprunter
is essential
pour pouvoir
because
atteindre
I
la
think that
couverture sanitaire universelle.
we know the path that we can use
Voilà
to
autant de
reach
raisons
universal
qui
health
font
coverage.
que
These reasons
pour nous,
explain why
nous nous sommes engagés à être
we
co-organisateurs
have committed ourselves to
du
becoming
réapprovisionnement
the
du GFF
co-organizers for
avec
the
le gouvernement de la
replenishment
Norvège,
of
la
the
Banque
GFF
mondiale
together with the government of
et
Norway, the
la
World
Fondation
Bank,
Bill et
and
Melinda
the Bill and
Gates.
Melinda Gates Foundation.
Nous avons d'autres aspects que
We
nous
have
développerons
other aspects
s'il y a
that
des
we
questions
will
précises
talk about if you have
sur
specific questions
l'engagement du Burkina
when it
Faso
comes to the commitment of
dans
Burkina
cette lutte-là.
Faso in this
vous
field.
remercie.
Thank you very much.
Okay, thank you very much for your comments on the role of Burkina Faso as a co-sponsor of the replenishment process and in itself leading its own reforms and work. Let's now turn to Ann Stars, who's president of Guttmacher Institute, who will tell us a little bit about how the sexual and reproductive health and rights community sees the global financing facility. What do you think has been accomplished? What do you hope to see going forward?
Great, thank you.
And she has slides soon. There we go.
They're coming up. Great. So as will not surprise you, and as Amanda said, the bulk of my comments are going to focus on the agenda of sexual and reproductive health and rights and how that intersects with and is supported by and supports the agenda of the Global Financing Facility. I'm first going to share a few comments just about the GFF as a whole. I, as Mariam indicated, strongly welcomed the establishment and welcome the success to date of the GFF. I think the creation of a global financing mechanism to focus on reproductive, maternal, newborn, child, and adolescent health plus nutrition. I'm now going to start using the acronym because that will save me probably about 5 minutes in my presentation. That has been the focus of global advocacy for many years and an explicit and strong aim of the Partnership for Maternal, Newborn, and Child Health and the Every Woman, Every Child initiative to efforts that I'm closely involved in. The health and survival and the well-being of women, children, and adolescents, we have seen major progress over the past 15 years, but as we all know, and as the data make clear, many challenges remain. And the existence of a financing mechanism that explicitly takes a holistic health systems, person-centered approach to addressing the needs of these populations comprehensively, that balances the disease or intervention-specific mechanisms that exist and that are working alongside the GFF, I believe this has the potential to really revolutionize the well-being of women and children. I also really appreciate the innovative model that the GFF embodies, in particular, the mobilization of domestic, private sector, donor, and the World Bank, IDA, and IBRD funding to expand on the impact of the GFF, and also the country-led, country-responsive approach that the GFF takes. Finally, in terms of the overarching comments, I enthusiastically, if still somewhat cautiously, welcome the GFF's very deliberate and systematic approach to engaging with civil society at the global and country levels through the establishment of the Civil Society Organization Coordinating Group for the GFF, the seats for civil society representatives on the GFF Investors Group, and perhaps most importantly, efforts to strengthen civil society engagement in the national platforms. Civil society, as I hope all of you fully embrace, plays a key role in ensuring transparency, inclusiveness, and accountability for mechanisms like the GFF, as well as in ensuring the voice of the community in discussions about priorities and needs. They can and do also play a key technical role. So much more needs to be done, in particular in the multi-stakeholder country platforms that need to engage civil society from the beginning, and they all need to do that. And we also need more work to make sure that the youth voice is consistently engaged. But I really applaud the GFF's Secretariat and the Investors Group's commitment to this important aspect of the GFF's operations. See if I can see the reflection. Yep. Can we go to the next slide? There we go. Thanks. So in early May, just before this year's World Health Assembly, the report of the Guttmacher-Lancet Commission on Sexual and Reproductive Health and Rights, so I'm now going to switch to another acronym, SRHR, was launched. The Commission challenges what we see as the quite limited view of sexual and reproductive health and reproductive rights that we see reflected in the Sustainable Development Goals, and proposes a new, bold, and comprehensive vision that aims to address sexual and reproductive health and rights needs of all people across the life course. The Commission's report highlights the enormous gaps in sexual and reproductive health and rights across the world, and quantifies the toll that those gaps take on individuals, on communities, and on economies in terms of maternal and newborn mortality, unintended pregnancy, unsafe abortion, and mortality and morbidity from sexually transmitted infections, HIV, and other sexual and reproductive health conditions. In fact, the report finds that nearly everyone of reproductive age, 4.3 billion people worldwide, will lack at least one essential sexual and reproductive health intervention at some point in their lives. The report includes a set of recommendations for national, regional, and global policymakers, health practitioners, educators, and health and rights advocates. Given limited time, I'm not going to go through all the recommendations, but wanted to focus on two key ones: to adopt and apply this new comprehensive definition and vision of sexual and reproductive health and rights that is in the report, and to progressively expand access to an essential package of sexual and reproductive health interventions. One of the key contributions in the Guttmacher-Lancet Commission report is the notion that sexual health, sexual rights, reproductive health, and reproductive rights are distinct but interlinked components, and that SRHR has to be addressed as an integrated whole. The Commission's definition reflects an emerging consensus on the services and interventions that are needed to address the needs of all individuals. It recognizes that improving sexual and reproductive health depends on advancing sexual and reproductive rights. As such, the report is based on evidence but grounded in human rights principles. It lays out the sexual and reproductive rights of all individuals to have their bodily integrity, privacy, and personal autonomy respected, to freely define their own sexuality, including their sexual orientation, gender identity, and expression, to decide whether and when to be sexually active, to choose their sexual partners, and to have safe and pleasurable sexual experiences, to decide whether, when, and with whom to marry, to decide whether, when, and by what means to have a child or children, and how many children to have, and finally, to have access over their lifetimes to the information, resources, services, and support necessary to achieve those rights, free from discrimination, coercion, exploitation, and violence. So as mentioned, the report proposes an integrated package of essential sexual and reproductive health interventions that are summarized, on this slide. The majority of so-called SRHR policies that we see in many countries and in many organizations tend to focus on the top three elements that you see here: HIV, sexually transmitted infections, contraception, and maternal and newborn care. We see this same focus reflected in many of the investment cases with, in addition, a strong focus, which I very much support and appreciate in many of the country investment cases on adolescent sexual and reproductive health. But in fact, the sexual and reproductive health interventions, this essential package, includes a broader set of interlinked needs, and a full package of services should include what's listed in the second row: safe abortion services and treatment of complications from unsafe abortion, prevention, management, and treatment of infertility, and the prevention, detection, and treatment of reproductive cancers. Finally, the package should include accurate information and counseling on sexual and reproductive health needs and issues, including comprehensive sexuality education for young people. It should include the provision of information, counseling, and services for sexual health and well-being, and crucially, the prevention, detection, and counseling around sexual and gender-based violence and coercion. Along with the package of essential interventions, the Commission also shines a light on the need for additional support that is for groups that are often marginalized, disadvantaged, or subject to discrimination. And again, I won't go through all of those, but adolescents and people living in humanitarian crisis settings are key priorities in terms of these disadvantaged groups. I'm just going to mention briefly the Democratic Republic of Congo, one of the countries that's profiled in the GFF's report. That report has, the country profile that's there has some very important information. What's left out of that report is that 6 out of 10 pregnancies in the Democratic Republic of Congo are unintended. And the abortion rate, despite abortion being illegal, is 56 per 1,000 women of reproductive age. That's the statistic for Kinshasa, which is one of the highest in the region. Contraceptive prevalence rate is very low, which is what contributes to and causes these high rate of unintended pregnancy and a high rate of unsafe abortion. So my point is that you need to address, you can't just pick on some elements of this package. You need to address this comprehensively. The report makes the case for greater investments in sexual and reproductive health and recommends securing sustainable domestic and international financing to close the gaps that exist. We have done the analysis. The cost of the core elements, the contraceptive, maternal and newborn health, and safe abortion around the world in developing countries would be $9 per person per year. We haven't costed the full set of the package because we don't have adequate data for that. This is a very affordable investment. Half of this is in fact what countries are already spending on this set of issues. So we see this as a very achievable target. That's it for my presentation. What's up here is a list of links if you want to get access to any of to the full report or to an executive summary version. And I think somewhere around here there's copies of some of the materials. So thank you very much.
Excellent. Thank you very much, Anne. Okay. Sean, you're the Director of Nutrition at the Bill and Melinda Gates Foundation. I saw that almost a fifth of funding actually is going to nutrition interventions through the GFF. Do you want to reflect on that and in general how the foundation sees GFF, its role going forward?
Sure. Thanks, Amanda, and thanks, Mariam, also for inviting me. Mariam and I used to be neighbors at the foundation, the office next door, and so I told her one of the privileges of coming here is I get to be next to her again. And as you said, I'm the Director of Nutrition at the Foundation, but I'm also representing a broader perspective of the Bill and Melinda Gates Foundation and what drove our initial investments and drives our continued enthusiasm. And so I actually was going to start out with a few reflections and share with you some of my 5 obsessions, those at least that I can talk about publicly. First, complacency. Second, missed opportunities. 3, scale. 4, investment, and then 5, accountability. And to give you a flavor, to start with complacency, and I think we've all seen today some of the progress the world has made, and the spirit of the Goalkeepers report that Bill and Melinda launched at the UN General Assembly last year did show great progress, but there were also these very frightening scenarios of what backsliding would look like and how it's real possible. And this backsliding is happening in real time. And here I'll share with you an example of vitamin A supplementation, which is something I have cared deeply about. It's one of the most powerful child survival interventions you can do. And by 2009, 80% of children in countries with vitamin A deficiency had gotten to 2-dose coverage. And so we really had made huge progress. But a report issued by UNICEF just this year shows that we've actually been, and we've dropped by 15 points, and that we've dropped most in West and Central Africa where the need is the greatest. And so this is a concrete example. If we don't pay attention, if we become complacent, we backslide. Backsliding translates into more deaths. I'm obsessed about complacency and how do we avoid it. Second, missed opportunities. And I was going to share 2 anecdotes. One, I was on the technical review panel of the Global Fund for 8.5 years. And we would review malaria proposals. I'm not to pick on malaria, but you'd be this very perverse situation where, for example, countries would be funding rollout of rapid diagnostic tests for malaria, but then wouldn't really know what to do. This child who presents to the health facility with a fever, tested for malaria, no malaria, the health worker doesn't have the resources to do anything, is going to send this child back home. If our system is not making sure that fever is taken care of, then we've missed an opportunity to very likely save a child's life. And I think I'll take a nutrition example, as we're seeing huge increases in the numbers of women who give birth in facilities who have assisted birth attendants. But we don't see an equal increase in initiation of breastfeeding within the first hour. Again, one of the most high-impact interventions you can do. A case in point in Nigeria of only 40% of women who give birth in a facility initiate breastfeeding within an hour. So we're missing these huge opportunities. And I posit that, unfortunately, the fragmented way we funded health has actually created some incentives that don't allow us to really seize these opportunities to the best we can for every mom and child who presents. And I hate missed opportunities. I'm also obsessed with scale. And if we cannot take these key interventions to scale at high quality, then we're not going to reach the people who need it most, and we're not going to have the serious impact and keep this trajectory going. But I'm also a pragmatist, and I think this is where the discussions get difficult, because we know we're working in systems like the special advisor to the president of Burkina Faso, you said. Sometimes the infrastructure is weak, and in most of these countries that are eligible for the Global Financing Facility, the infrastructure is not that strong. And so there are huge trade-off decisions of what is the priority package of interventions we can actually take to scale and do high quality. And that is a difficult discussion that has to be informed by the evidence base of what impacts are there, what populations do we need to reach, and what can the system actually deliver on, and then how do we build it over time. My fourth obsession is investment, and I think it's the fundamental change in the language you use. I think for far too often, finance ministers are not evil people, I've learned in the last few years. But we've actually presented them the idea that, oh, this is a cost you have to bear. And what we've seen in nutrition, and Mr. Special Advisor, you pointed this out, is we flipped the message to say, well, look, this is what the stunted child is costing your economy. We've all of a sudden flipped the narrative that this is not, in fact, the cost is not the nutrition interventions, the cost is inaction. And I think for all of this, what we need to do is really flip the narrative. The costs are poor health and poor nutrition. The investments are what you make to ensure that populations have good health and good nutrition. And this becomes an investment in the country's human capital. And then my fifth is accountability of that we've got to provide, the country stakeholders need to have the good information to make smart decisions, to monitor and course correct, so you adjust to make sure the right interventions are getting to the right people, and that all stakeholders, governments, private sector, non-governmental organizations, donors, are being held accountable. And so when I think of my 5 obsessions, I think this is why Bill and Melinda and the many stakeholders within the foundation made this decision early on that, wow, this global financing facility mechanism has huge promise. It has huge promise to keep the focus on national and global commitments to accelerate gains in saving lives and improving nutrition, to better align financial resources so that opportunities and impact are not missed, to facilitating these difficult conversations that identify and set priorities of what we're going to take to scale, create incentives for governments and their partners so that when you're having these conversations with finance ministers, you're actually having a positive conversation about why to invest more in health and nutrition, and underpinning all of this to actually build those data systems and that routine review process so you're holding people and accountable, I use in the broadest sense, but you're actually providing information for good decisions, you're allowing stakeholders to course correct, and then holding everybody accountable. So I came to the table today with about two perspectives. One from having heard lots about the implementation of the Global Financing Facility and having read the annual report, and then also a bit more of a personal perspective because I've had the opportunity to spend several weeks in Burkina Faso the last year speaking with many colleagues and involved in some of these missions looking at the Global Financing Facility. And I walk away, I think, extremely optimistic. I always will want more. I think we all do, that's why we're here. But you can see clearly as Mariam presented some of the great gains we're seeing. I think one of the challenges is its very strength, is that as a process that is very country-facing, every country looks a bit different, which is how it should be. But it's hard to say that when you're riding down the elevator sometimes with a donor, but that in fact is this huge strength. We're also seeing, I think, incredible improvements of the amounts of investments that governments are putting to the table, both their true domestic resources and the concessional financing. And you know, to me, no country illustrates this better than Burkina Faso. And it's been the extent to which there's been national leadership from the Minister of Health, from the Minister of Finance and Planning, the deep commitment, despite the huge burden on the public purse in Burkina Faso, as was laid out earlier. Throughout the Sahel, resource generation is not an easy thing, and you're hit on top of this with an enormous security threat. And despite that, Burkina Faso is maintaining its level of commitment. Health and nutrition are central to the National Economic and Social Development Plan, so not marginalized in just some health or nutrition plan. They are central to the government's commitments. And it really has been a rallying call of how do the different parts of the government, different stakeholders, and I've been involved in a couple of visits just, I guess, a little over a month ago, and to see the level of engagement. For example, there was one workshop among nutrition stakeholders, a full day, chaired by the General Secretary, the Permanent Secretary of the Ministry of Health, to really hash out this difficult decision of bold nutrition plans have got lots of interventions. How do we narrow it down to those things that we absolutely have to take to scale? So I think I come to the table again with my obsessions, but seeing how the Global Financing Facility is really helping to respond to them. Thank you.
Thank you. Thank you, Sean. Okay, as moderator, I also allocated 5 minutes to myself. That's smart. I wanted to just reflect, first to just re-emphasize a couple of wows that this report gives us, but not also to share with you 3 worries. The leverage, the leverage of the Global Financing Facility dollar on IDA, IBRD, and government budgets, 1 to 7. I don't think you'll see that in any other aid mechanism. 2, spending prioritized to the most cost-effective interventions via a package, including the highest priority in neglected areas in global health, things that have fallen through the cracks before. The alignment goal, the idea of trying to consolidate funding flows to providers or subnational health authorities under a single performance contract as in DRC, the linking of disbursements directly to performance, and a really quite a small additional ask for big leverage. So I think those are all some big wows that I see in this report. Another aspect that I thought was quite interesting is the use of the World Bank's comparative advantage across the health and finance sectors. So in Cameroon, they describe a fiscal reform that's ongoing where the GFF and the World Bank teams can be together to talk about the budget treatment of health. That's a very unique and special thing that only a multilateral development bank like the World Bank can bring. So those are some of the wows that I see coming out. I have a couple of worries. One is related to the donors. So if it's such a small amount of money, why is it so hard to get that extra $2 billion? We have a number of replenishments coming up next year. I think this mechanism has shown its value and fit for purpose. Why is it so hard? A second is around this alignment issue. How will we really get donors to align around what this is, primary health care, the most basic kind of health care? One of the very great statistics that are included in the country profiles is the share that is pooled or put together in the government budget. So a country like Kenya, that in the next 5 years is likely off of most of those external resources, only 31% of external funds are on budget. And I ask myself, why is it that donors are still fearful about pooling if it's the World Bank rules and procedures that are going to be governing that expenditure? All of the governments are running money through the World Bank too. Surely we already agree that this is rigorous enough. Why is it so hard for us in global health to pool in order to improve efficiency? And I mean, we can get into all the examples of inefficiency in this way, but it's really a missed opportunity. And I hope to see more. In a country like Sierra Leone, only 7% of money is pooled. So in the least capacity settings, we are making the world so complicated for our partner governments. A second worry that I have is the inevitable Christmas tree problem. And this, I blame myself here in civil society as a think tank, but on advocates, and that is that when we see a beautiful financing facility or pool of money, we want to hang every ornament on it. Sometimes we pile it up so much that it falls over and can burst into flames. So I see a lot of competing demands facing a very small secretariat trying to work in many countries in the context of the World Bank. That is so hard, and I think just one thing to say, if we all are trying to earmark and see our own issue, that we should try and appreciate some of the interesting ways that the Global Financing Facility is trying to put in place to mediate and negotiate and to work with governments to set their own priorities based on cost-effectiveness evidence and given the real budget constraints that face those countries. That's going to require some understanding and discipline from those of us on the outside. A third worry has to do with other global health funders. How other global health funders are relating to governments, and by extension the Global Financing Facility, will be important if we want to see global health gains sustained and progress made to primary health care and universal health care. I feel like we're all over the place in some of the different funding mechanisms. We mentioned the off-budget issue. If you are off-budget in Kenya, and you're going to be out in 5 years, what's the plan if you're running most of the money through non-governmental organizations, particularly in the area of sexual and reproductive health? Is it that we hope that government will contract these NGOs? Is it that we are building up a new private sector philanthropy source of funds that's going to go into those NGOs? I don't yet feel that we're serious as a community about what happens and what role government is going to play with respect to primary health care interventions. And then finally, the issue of performance verification and evaluation. I think we solved the problem of the elevator pitch. This is not a problem of the Global Financing Facility, but it is a feature of the Global Health Financing Facility that it is focused on the country itself, the problems that the country faces, the way that they would like to resolve it, the way that they prioritize. But that means that they're doing something different in every country. The only way we can talk about this coherently is to really be aligned on the results that are going to be achieved, and that countries and the financing facility align on those results, and that we agree on standards to measure and report on that progress and evaluation. And that way we'll know if we are seeing real efficiency improvements and productivity gains. And I think the World Bank is already doing this in so many ways. So with that, I'll end, and we'll now turn it over to our panelists for a couple more questions, and I'll go to you in the audience in about 2 minutes, so get ready. So first, I'm going to ask our colleague from Burkina Faso about this issue around donor alignment. What are some creative ideas to get donors more on the same page? And I'm not talking just about I'm aligned to the plan, because donors have been aligning to national health plans for decades. What we really want to see is the money going in a systematic way towards the priorities in primary health care. So what thoughts do you have in the context of the Global Financing Facility on this issue?
Non, comme je l'ai dit,
Well, as I said earlier,
comme je l'ai dit dans mon propos,
as I said earlier in my discourse,
mes autres collègues aussi ont
my other
intervenu
colleagues also
là-dessus.
did say,
Je crois qu'il faut
did talk about it. I think that
plutôt avoir le courage de dire
we should be courageous and say
la
that
transparence
transparency
fournie par le GFF
that is given
pose
by
véritablement
GFF is
un
really
problème.
the main maybe
Parce
issue,
que
because
les différents pays
all countries or different
et les
countries
différents donateurs
and different
ont
donors
eu l'habitude
have been
d'une certaine
used
fragmentation
to
de leur
a
financement.
fragmentation of their
Et quand je
financing
l'écoutais,
or
d'ailleurs, j'étais
funding.
content parce
I
que
heard you,
vous avez
I
des
listened
gens,
to you. You have people,
des donateurs qui, à
donors
travers
who,
des ONG,
through
par exemple,
NGOs, for instance,
vont financer
will fund
la santé sexuelle.
sexual
Vous avez
reproductive
d'autres qui
health.
vont financer
Others will want
la
to
santé
fund health,
de la reproduction. Ainsi,
reproductive health.
et vous n'avez aucune coordination
And thus you have no
entre
coordination
ces structures.
between
D'une
the different
part,
structures.
c'est
So
le
on one
donateur
hand
qui
you have the
définit
donor who
la
will define
priorité,
the priority
pas
to be
forcément celle
funded.
du
That
pays.
might not be the
Et
priority
c'est
for
lui
the
qui
country.
finance.
And the donor
Et
will fund,
je crois
will
donc
give
que
the money. So I think
c'est cette approche
this type
qui
of
nous semble, nous en
approach
tout cas,
is in
très
our
négatif,
eyes rather negative,
parce que il faut avoir
because
une
you
vision
should have
globale
a
de la
global
question de la
vision of
santé,
the
de la
issue
mère, de
of
l'enfant, si
health,
c'est dans ce
mother,
domaine qu'on
children,
décide
if that's where you decide to
d'aller.
invest money.
Et aujourd'hui, avec
And nowadays,
cette approche du
with
GFF là,
this
au moins on a
approach
la
by
garantie
GFF, you will
de
have a
la
guarantee
transparence.
that there will
On a
be
la
transparency.
garantie
You will have the
d'une
guarantee
définition claire de
of
la
a clear
priorité
definition of
ou
priorities
ou des priorités
or priorities
du
plural
pays.
for the
Ce qui
country,
permet quand même
which
de
enable
pouvoir
us
travailler
to work
raisonnablement parce
in a more
que
reasonable way.
il y a beaucoup de pays
Because
africains, quand vous
there
regardez
are many
aujourd'hui,
countries in Africa, if you look
il y
at,
avait une multitude de donateurs.
if you look at
Bon,
them, there are all
finalement,
kinds of donors.
Quand le donateur récoltait $100,
The
c'est une
donor
image que je
gives
donne, mais c'est pas
100.
forcément
That's just
des
an
chiffres
image
exacts,
that I'm
c'est une
giving
image que je
you.
donne.
It's just
Le donateur
an approximation.
donne
So
$100.
the donor will give
Déjà, lui
$100.
va utiliser peut-être
They will
$30 pour
use
son propre
$30
fonctionnement.
for their own
Ensuite, il
operating
va envoyer
costs,
une
and then
ONG qui va
they will
utiliser
work with an NGO
peut-être
that
50%
will
pour son
use
fonctionnement. Donc, finalement, le
25% for
destinataire
their own
final, vous de la
operation.
portion qui lui
So
arrive,
the
vous
final
demandez,
destination
etc. Et
will
aujourd'hui,
be
nous avons
just a
donc
small
un
portion of
mécanisme
these
qui permet de
$100.
transcender
So
toute
GFF
cette question.
is really
Voilà
a
pourquoi
mechanism
nous
that
sommes
goes
engagés
beyond
là-dessus, parce que nous
these
pensons que c'est
issues.
une
That's why we
vision et
committed
une approche
ourselves, because this is
innovante.
a new approach.
Yeah, thank you. Thank you for that perspective. And let me ask you about this issue of, because there are a lot of non-governmental organizations that are in the business, not the business, but in the provision of sexual and reproductive health care. What do you see in some different countries in terms of how financing fits or not with government, and what do you see as sort of the key issues for GFF thinking about this area?
Thanks, Amanda. Yes, I very much, while obviously I and my organization are focused on a specific element of the overall agenda and see sexual and reproductive health and rights as crucial to primary health care, to the well-being of women, not just mothers, but women, children, and families, and see sexual and reproductive health as fundamental to that, I fully support and endorse the fact that countries should be setting their priorities and donors should be coalescing in support of those priorities. Now, this question of countries setting their priorities, who within the countries is setting those priorities. And I think that's one of the crucial elements. I'm looking at Betsy McCallan from the White Ribbon Alliance, which supports advocacy coalitions in country to articulate and speak out about needs as they are perceived and felt by communities themselves. So I think part of what we need to see is that when countries are setting priorities, it's priorities around what are the most cost-effective interventions, but also where are the greatest needs, and where are there the greatest potential for synergistic approaches. And that's one of the points I was trying to make. You can't, maternal and newborn health, family planning is critical to that. So is either provision of safe abortion or management of unsafe abortion, because if that's a significant factor in maternal mortality and in management of unintended pregnancy. So I think, coming back to your question, what we'd love to see is donors genuinely coming in support of that. I think it comes back to one of your concerns, Sean, around transparency and accountability. Donors feel that I think in many cases, that they are accountable to their own populations and have to be able to report on progress that their funding has contributed to. If we could get a sort of a global consensus around support for a set of indicators, and that all donors are contributing to these achievements that reflect the priorities of the needs and the priorities of the countries and the needs of the people, I think that would help us ideally get to donor approaches that are more aligned with country priorities. The U.S. government is a challenge in that respect, and I'll just let John Barraza or somebody else address that one if they want to.
Man, come on. Okay, Sean, what about you're a funder of multiple global health funding agencies like the Global Fund, like Gavi. How do you see the GFF sit in relation to them, both at the international level, but also at the country level? Mm-hmm. How do you see their respective roles?
Yeah,
vis-a-vis government.
I think, so I'd start out perhaps at the country level, because I think that's where it's most important, in that in an ideal scenario, I guess I'm somewhat less obsessed about the idea of pooling funding. I think already if you get transparency, so there's actual visibility into who's funding what, and you can identify then based on what the priorities have been established, what is currently being funded under those priorities and where the gaps are. And that's, to me, is where I see that combination of the existing global financing mechanisms with the Global Fund is huge added value, because the Global Fund can actually, the GFF can in a way be a bit of the sauce that actually brings all these pieces together in a much more coherent way and fill those gaps of top priority interventions that have high impact and are reaching the people who are least reached currently. And so I see that as essential. And then how do we actually, and I think the current situation about the extent to which these other global mechanisms are actually coordinating well in country, I think we have some very good cases, and I think we have some cases where there's a lot of work to do. And certainly from our perspective, we're trying to encourage these to work together. At the global level, I think the first thing to say is that this is not a competition, I would say. As you said from the beginning, this is actually a very modest ask for replenishment for the trust fund. And Mariam can go on better about this than I can, but I think it's also important not to reduce the global financing facility to just the trust fund. It's actually the mechanism itself, and the trust fund is one piece in the toolkit to make this happen. And we all see that increasingly governments of high burden countries are going to have to bear more and more of the weight. They've always borne a huge amount of the weight. Often that's not been as visible because at the end of the day, they're paying the salaries and creating the infrastructure. But that share is going to increase. The ability to create a system where you're having these direct dialogues with ministers of finance, using the different levers that the GFF Secretariat has, the World Bank has, to get higher priority to these critical areas, and a long-term plan, I think, is essential. And that's something that the other global facilities have done. I would say they didn't start out there, and they're trying to invent it now. Whereas I think that's been the very core of the GFF thinking from the very get-go.
You could envision it as a kind of sequential process as well, right? Because as countries get wealthier, some of them will be ineligible for other sources, and so GFF has a really important role to play as a puzzle piece there in the transition to sustainability. So Mariam, you've heard all about our wows and worries and thoughts that have come out. Do you have any reflections on what the panel has talked about so far? And then we'll go to the audience for some questions.
Well, I grabbed a pen here because I thought when you were going to list your wow, that's fine, but when you were going to list those things that concern you, I thought I really have to think about that. But I must say you echoed the challenges that we have in a really nice way. I think Sean said something around the shift of the narrative towards investment, and the reason why we are so excited now in 2018 about financing for development is this broader framing that you also see from the World Bank, that it's about human capital investment, that recognition that's not a cost to society, but it's the best investment society can do, is investing in its people, and that means investing in health, nutrition, education, and other determinants of the future. And for us, that's a perfect framing. And to your point about being a small secretariat, I think the reason we can be a small secretariat is because it is a partnership. We are not the technical normative function of the world. We are not the best at implementation on the ground. So clearly, the role of the GFF small secretariat is really to be catalytic, not just financially, but with the resources that are out there. I think, for example, some of the crises we talk about today about, reduction in funding for certain areas, if countries had blended financing, if they had everything on budget, multiple sources of financing, that wouldn't be an issue. Things become an issue because of vertical, very specific funding that suddenly might lose momentum. So the more we can empower countries to play this role, provide the tools that they need, and the analytics, to do really good analysis that's not driven by earmarked interests, that's really how the future for us in development. And to be part of that is very exciting for us.
Excellent. Well, I think that's a good ending. Let's collect now 3 questions, comments at a time. Please say who you are, where you're from. Keep it short. And we'll start with our colleague, I think she's from Sierra Leone, right? Oh, that's Liberia. Okay. Great. Yeah. Okay. You're next. Get ready.
Good morning. I'm Mariam Suba. I work for Chipago in Liberia in the maternal charge of our program in the Human Resources for Health project. And that's where my question is. I want to thank all the panelists. I think this is a wonderful morning for me. Anytime you're talking about maternal newborn child health nutrition, very wonderful, and I heard some very interesting things, so thank you all. My question is, in looking at the global financing facility, you do not see so much of the emphasis on the human resources for health. Like this morning when we talk about the results, we talk about the service, that more people are doing OPD, more people are doing skilled birth delivery. But in countries like Liberia, we started to talk about more people coming to the health facility, but we find that when more people come, they do not have the staff, qualified staff to help. And so that investment into human resources is something that maybe you could comment on in terms of how with the GFF. Thank you.
Excellent. Thank you. Over here.
Good morning, everybody. I am Juliet Laverly from Sierra Leone. I am a private sector player, and my motto is bringing healthcare to the people. We have, as my friend in Liberia has stated, we have a huge challenge in the infrastructure and healthcare workforce capacity. So taking the healthcare to the marketplace where the moms would get their vaccines right there where they work and making it flexible and possible for them to get the care. My question is, as a private player, what incentives are being given to people like us in terms of the packages and the financing to our leaders and governments?
Excellent question. Okay, one more there in the back.
Good morning, everyone.
No, it's good. We have a webcast.
Oh,
so,
okay, all right,
thank
thanks.
you.
Good morning. My name is Eboa Ewoma. I am a Global Health Corps Fellow, and so I'm working with the Global Handwashing Partnership at FHI 360. So my focus is actually knowledge management in the research and advocacy we do. So my question is, because a number of the panelists spoke about the innovative approach that the GFF takes to its work with countries, so actually working with countries through their systems to actually deliver solutions in nutrition and healthcare. A number of them focused on the work in reproductive healthcare. So my question is, does the GFF actually actively advocate for thought leadership in this approach? How do you encourage other institutions to adopt this approach, and how do you push this message in academia? How do you make it more sustainable for people to consider doing things this way? That's my question. Thanks.
Okay, let's take one more. Okay, Arjun. We'll let a man talk. Why not?
Thanks, everyone. My name is Arjun Basana. I'm with the U.S. Treasury. I have two quick questions. One, can someone comment about how the GFF is engaging with the Human Capital Project at the World Bank and the index that's supposed to be announced at the end of this year? The second question is around, I heard a lot about alignment at the strategic level, but I'd like to know more about what is being done to align budgets of donors with country budgets and charts of account, and to ensure that expenditures of the donors are also aligned with the country systems and the financial management systems and what the GFF is doing. Thanks.
Thank you. Okay, so we have 4 great questions. Mariam, I'm afraid you have to take some of them. But then we'll also ask our colleague from Burkina Faso about the issue of human resources for health and how it relates to service readiness. And also the issue of partnership with the private sector and with the not-for-profit sector. How is that's really a government question. It's not a question to the GFF, because presumably the GFF supports what the government considers to be the most effective delivery mechanism, with some advice involved. So maybe we'll ask you to say that, to respond to that. But Mariam, do you want to sort of give an overview of response, and then we'll go to our other panelists?
Great comments from Liberia. And Liberia, as one of the members of the GFF Investors Group, have always put on the table, first of all, that it's all about, for Liberia and many countries, especially post-Ebola, about building more resilient systems and the front lines. For us, it's not about the last mile, it's about putting the front line first. And as you will see, even in Liberia, much of the resources are steered to those parts of the country where really you have the poorest MNCH indicators and where the greatest need is to really build resilient frontline systems. And you talked about frontline health workers. We also would like to embrace a broader sort of community health systems approach. So it's both about providing frontline workers with what they need in order to deliver, but also think really more in terms of systems and building systems. And of course, you and your organization is a very important member of that jigsaw puzzle. What is it? And I know that's very important in Burkina Faso. We often hear from Professor Meda, the Minister of Health, how important it is to get those frontline health workers out there. It's not just about soldiers in the front lines. It's really about building health, supporting frontline health workers, and we really embrace that and support that. The learning knowledge management for us, USAID has been a wonderful partner in terms of strengthening the learning, innovation, thinking innovatively around knowledge management. So what the GFF countries already have is a south-to-south learning network. They meet regularly to discuss issues, share best practices, and try to disseminate the information. For us, that's a very, very important piece of what we try to do. Since you are from the Treasury, I have to tell you that one of the things that is an advantage of being a global mechanism in the World Bank is, of course, also that we can work with the bank's Treasury. So we've just issued, the Treasury of the World Bank issued a sustainable development bond recently to try to attract investors towards women, children, and adolescents and working with us in the GFF. And for us, that's a very exciting opening towards getting private capital to countries that needed to tap into that. But of course, what you listed, and which is, again, a centerpiece in what the GFF does with countries, and which we do because we have access and work with ministers of finance because of our close being joined in the hip with the bank, is really working with ministers of finance about getting things on budget. That's really central. And Amanda, you talked about that. We hear people say, well, we are all on budget. Yeah, each one has their own budget. We worry about the country's health finance plan and health budget, and that's really what we support, and the country's systems rather than setting up separate systems.
Okay, Mr. Sharif, would you like to say something about the issue of private sector involvement?
Oui. Non, je crois que Chef
Yes,
avait
I
déjà un
think
peu répondu
that you have already answered
à cet aspect.
and this item.
Cette participation est
This
bien
participation
entendu,
is, of course,
souhaitée.
wished for.
L'essentiel, comme je le
The
disais
essential
tantôt, c'est
thing, as I said
qu'il y ait de
earlier,
la transparence.
is to have
Sinon, tous
transparency,
les acteurs qui peuvent
because
financer
all the actors who could finance and fund
sont bien reçus.
will
Moi, ce
be
qui
well
me-
received.
Ce n'est pas une obsession, comme on a dit,
It's not
mais
an
c'est
obsession,
une
as you said,
tarabuste.
but one thing that
L'esprit,
is
c'est parfois le
a
rapport
question
qu'on
in my
veut
mind
établir,
is the rapport
entre
that you
les
would like to
budgets
have between
et la
budgets
santé.
and health.
J'arrive pas à comprendre parce que
I don't
pour moi,
understand because for me,
le premier des droits humains, c'est le droit à la
main
vie.
human right is
Et le
right
droit à
to
la vie n'a
life,
pas de coût.
and it has no cost. It doesn't
Il
have
faut
a monetary
simplement
cost. You should
assurer ce
make
droit à la
sure
vie.
that
Parce que
the
chaque
right to life is
jour,
there.
voir des
Because
milliers
each day you
d'enfants
see
disparaître,
thousands
des
of
femmes
children that will die, women
disparaître ou en
who
tout
will
cas
die also,
mourir sur
and
des tables d'accouchement.
they will die because
ça
they're
ne-
delivering a
on
child.
quantifie pas ça.
So
Il y a
you
pas de
cannot
rapport
quantify
entre,
this. There is no relationship between
affaire entre un coût, il
between
faut
a
qu'on ait
cost
les
and
moyens,
this. We have to have the
justement, de
means. We have to
sauver,
have the money to save
toutes ces vies-là.
all
Pour
these
tout le
lives.
reste,
For all the
ça
rest,
reste maintenant
then
l'engagement
it should be a commitment
des différents acteurs,
for all the
que
actors,
ce soit les gouvernants,
be
que
they
ce soit les
governments
gouvernés, que ce soit
or
la société
the
civile.
population
Il faut
or
que
civil society.
tout le monde
I think that
s'engage
all should be
sur des
committed
questions
on
bien
issues
précises.
that are very specific.
Parce que il appartient quand
Because
même
it
à
behooves
l'État d'assurer la
the
santé
state or the
de
authorities
sa
to make
population.
sure that their
Donc, quel que
people
soit le
are
mécanisme
healthy.
que nous
So
mettons en place,
whatever
ce
mechanism
mécanisme
we
ne fait
implement,
que
this
venir en
mechanism
soutien.
will
Mais si
also
les États
only support.
eux-mêmes
But if the state
démissionnent de cette
themselves
responsabilité,
are not in charge of this
forcément,
responsibility
vous avez
of
vous
the
aurez des
right to
problèmes.
life, then
Et je
you'll have
pense
issues.
que
And I think that
c'est là aussi la
this
nécessité
is
de
where it is
plaidoyer, que ce
necessary
soit au niveau
to
politique, que ce
support
soit au niveau
policies,
financier, etc. Mais il faut
support funding
travailler à
also.
assurer
But we have to make
cette
sure
responsabilité,
that this
ou du
responsibility
moins cette responsabilisation qui nous
this
appartienne tous. Et
responsibility will be given
j'insiste et
to
je
all. It
persiste
is
que
to
le
all,
premier
and I
droit,
should make sure that the first
humain,
right,
c'est le droit
the first
à la vie.
human
Et à
right
partir de-
is
c'est à
the
partir
right
de
to
cette
life,
vision que
and from
on
this
peut
vision,
décliner ou dérouler
then
tout un programme.
you will be able to have a whole program designed.
Thank you. Let's go back out to the audience for a couple more questions or comments. Let's see. I can't remember. In the very back.
Hi there, Rosalind McKenna from Open Society Foundations. And it's really just to link the points from Mariam and from Anne around if the Secretariat is not playing that technical or normative function. What do we do when we then see gaps in, for example, that kind of comprehensive package of SRHR intervention that the Guttmacher-Lancet Commission identified? So really, allowing for the country ownership piece, what do we see when those gaps are not being filled?
Mm-hmm. Other? Over here in the second row.
Hi, my name is Samantha. I work with Results for Development's market shaping practice. And I wanted to ask a question kind of looking at in-country transparency of when GFF funds arrive. We're very excited to see some of the countries we work in to increase access to child health commodities are now GFF countries. But in some of these countries, there is ambiguity in when funds are arriving, exactly like what bucket of the fund is dedicated to child health commodities. And we've seen that impacts ourselves as well as our in-country partners to really coordinate how to mobilize the application of those funds. So if you could comment on how to improve or what efforts GFF is currently taking to ensure that there's in-country coordination on the transparency behind the funds.
Great question. Up here.
Hi, Jim Tilch from George Washington University. I've got a ton of questions, but I'd actually like Mariam to tell us a story. And the story is about the prioritization process that countries go through. And I'd like you to tell us what the challenges have been in terms of focusing a country in terms of that prioritization process. Do you set a cost-effectiveness envelope around the pieces of the packages that you're talking about? Do you talk about how do you balance that with equity across different subgroups of the population, that whole process? So just an example of a successful one, and one may have been frustrating a bit to help us understand that process.
My very favorite topic. Thank you for making that question. Okay, so 3 actually quite tough questions. Anne, can we start with you a little bit on this issue?
We could. I'd actually,
yes.
Before I answer that question, I'd like to hear Mariam's response to this last question. And
All
I'll
right.
follow up on that.
All right, so you have 3 big ones, Mariam. If you're not playing the technical normative function, who is? And then what to do if gaps or issues are seen. Second, around transparency in when the money arrives, who's managing it, and what commodities will be financed and purchased by whom. And then a third around priority setting.
Really great questions. And to the first point, of course, we have technical experts on our team in each of these areas. And we have a child health expert seconded from UNICEF on our team. We have a reproductive health expert from Mary Stopes previously on our team. We have probably the best expertise in our small team. But we are not, what I think is so important is that the GFF is a partnership, and it is about country-driven partnership, so that countries, we of course play a very important part of the quality aspects of what we support and invest in, but it's really up for countries to set the priorities in a very evidence-driven way. So to your points, we see ourselves as the mechanism by which you address gaps, neglected population groups, neglected groups, that is usually early years and adolescent, neglected parts of the countries, usually in fragile parts, and the neglected interventions that we talk about here, high impact neglected interventions. And you see that reflected, I think you will notice that in all of the investment cases. And that's why also we allow for country adaptation to circumstances. We talked about gender-based violence. Of course, counseling for victims of gender-based violence is one of the indicators in the DRC's investment case. Of course, in Bangladesh, in the education project, dropout rates among secondary girls are a key indicator. So we really are trying to not earmark, allow countries to set priorities, but do that on the basis of best evidence and drawing in the partners who have the know-how in these areas. And that's what's so important, that things aren't driven. We don't want to become a 200 staff team that runs the show. We do want to have a country-driven mechanism where we rely on partners for excellence. someone around child health commodity, it captures so well, you use the word ambiguity, right? And that is what we're trying to address in a very serious way moving forward. There shouldn't be ambiguity around where in the face of a investment case implementation country is. So that is something I said are among the things we are working on going into the future, to have a liaison person, so you could always ask that question and get an answer or delegate it. Much more transparency around the process and where one can step in and where things are, in particular, as countries are moving from design to implementation. Where are we with the stockouts? And since we have a colleague from the private sector, one of the things that we, of course, work with the private sector on is getting supplies to the last miles. Learning from Senegal, who was able to really, through a very excellent systems called the push system, get commodities to where they were needed. How can we expand that, expand it to other commodities and to other places? The story is what we are trying to capture in some of those 3 stories in the report, because there is the story of the country, some countries who really from the very beginning had a very inclusive conversation, because as Anne, as others said, when we talk about country-driven, it's government and civil society. Countries are made up of both. So it's those countries who really had that inclusive process, so that when you define your priorities, there's ownership around those priorities. That helps with alignment. And then being able to move things forward in an inclusive, transparent way. And, I don't want to highlight any particular countries here, but I'm happy, in terms of inclusivity, the process in Senegal in particular, in terms of getting all partners on board. Sometimes those processes take longer. There are a few of those very short, rapid processes where you then have to go back and retrofit, where you didn't have the same kind of inclusive engagement, also bilaterals on the ground. So I think that's where I see the biggest difference between the best case scenarios is it's not really what they did and how they worked with the Minister of Finance and what priorities, but how they did it. And that's where I feel we need to really do better, learning from the best practices. Inclusiveness, transparency, evidence, and using good tools. So we are putting together a source book of good tools that countries have used. Many use the Quist tool of the UNICEF that helps to use available data to do better equity analysis. We're trying to mainstream more of gender analysis and do that in all operations. So I think it's a very exciting time to try to see between the best practices and those others. And then, of course, we will have an evaluation of our whole effort in 2-3 years from now to see, also not just help countries to monitor, but using that information to evaluate progress.
Okay, interesting.
You might have something to add to this.
Yeah, I was going to make the links to, so this is more from a nutrition perspective, and it's linked to, these discussions about who's included, but particularly then what does one fund. The Scaling Up Nutrition movement started in 2010 and driven first and foremost by better country coordination under strong government leadership, and it brings together, there's a country focal point, it brings together different ministries within the government, but then also brings together the UN, the donors, the civil society organizations, in some countries, the private sector. And in fact, that movement and then participants in it have not only helped develop nutrition plans, but then costed those plans. And that's become, in many countries, then the intersection between the Scaling Up Nutrition movement with costed plans that have been prioritized, and what are the gaps, and then the global financing facility, the IDA allocation of the trust fund, saying, okay, what of that can we actually do? So that doesn't always work out perfectly, but I think it's a good illustration where the GFF is to build on existing mechanisms, not come and say, okay, step out of the way, we're here to do it right now. It's how do we actually continue that country level dialogue? And so I think that where it has worked out, and you've seen, it's actually been a very good situation of linking up existing capacities on the ground, both from government and its development partners, with this mechanism.
I mean, one thing to say is, as countries move towards universal health coverage, many of the ones like Thailand or others that have the most successful priority setting systems, they do a couple of things. One is that they're based on evidence, but they they set rules of the game for how a priority gets to the public budget. And it's easier to think about it with a specific kind of product, but it's also true of an intervention or policy. But one thing that has worried me in global health in the past is that we do have costed implementation plans and gap analyses in 15 different areas. And we have groups that are very passionately and very legitimately interested in seeing those priorities on the public budget. And so governments themselves have to juggle those different priorities in the context of a budget constraint. And I think GFF could play a really important role building that capacity, the systematic capacity to consider evidence, to weigh the relative importance and transcendence of one intervention versus another, taking into account synergies and all the rest, and then assessing the budget impact and then making recommendations. And I think that's a very important area where you could contribute. I know that Kenya is starting to think about that now. We actually have a book on that very topic that I will give to you afterwards. I'm sure that will be useful. But Anne, do you want to have say something about the issue of sexual and reproductive health in particular? There's a rights argument for a lot of different interventions, and the question is, well, how does it fare in cost-effectiveness analysis? How to take other considerations besides cost-effectiveness analysis into account? What have you seen in country?
Well, I think on the contraceptive services and in terms of maternal newborn health, there's no question that the evidence is very clear. Contraception in particular is an incredibly cost-effective intervention because by preventing unintended pregnancy, it actually saves countries a significant, and our Guttmacher's adding it up analysis very clearly demonstrates that investing in contraception to prevent unintended pregnancies actually saves significant resources that would otherwise have to be spent on maternal and newborn care for unintended pregnancy. So that's a relatively straightforward one from that criteria. It does get more nuanced when you start looking at some of the other elements of sexual and reproductive health. There is evidence where we may lack evidence in some cases, and in other cases where there are issues around where essentially these issues are controversial. So abortion, adolescent sexual and reproductive health, although again, as I mentioned, I've been very impressed with how strongly, how many of the country investment cases do have a strong focus and emphasis on adolescent sexual and reproductive health. The sexual and reproductive health needs of sexual and gender minorities, for example, is another area. The cost here, so I guess in addition to the cost effectiveness of the interventions, there's the equity issue, which Mariam has mentioned. There's the scope of the need, but there is, I would argue, there is an element of taking a rights angle to this. And part of the rationale for doing that, I think, besides just that it's the right thing to do, but it's also, you have to look at the issue of demand creation, right? And the better that you're meeting people's needs comprehensively, the more likely people, particularly women and families, are going to be to use resources, use health services consistently and effectively. So I think there is, even if you aren't too keen on the rights angle per se, there is a strong argument for designing services to meet the needs of populations, including neglected populations.
Absolutely. Okay. Yes, Mariam?
Yeah, you wanted me to come first, so now you got first on that. And just to say that, of course, in the GFF, since we do we follow countries' policies and invest in what is the national policies. It's not our role to, you help inform policies and you influence policies by providing the evidence, but we really do. And one thing we do is we do invest in comprehensive SRHR. And because adolescents are so important in these discussions, and since they are included in the priority setting, what are their challenges? Of course, when you work on adolescent health, you end up working across sectors on social protection, gender, education, health. It doesn't become a singular health services provision. It is about adolescents' voice, adolescent engagement, and for us, that's a very important part of what we do.
Yeah. Okay, do you have any comments on this set of questions, or shall we go back out for one more round? Okay, so one more round in the back in the blue shirt.
Hi, I'm Cicely Thomas from Results for Development, and this is really a question for you, Mr. Sai. We've talked a lot about this country-led process, and we've also heard from Mariam about the limitations of the expertise at the secretariat level, being able to provide that expertise at the country level. I'm wondering from you, from the country perspective, what are the needs that countries have technically to really implement on the plans that they're working on with all of these donors? So are these needs for strategic communications to better dialogue between finance and health ministries? Are they more health financing needs? And then my follow-up question to that is, who do you go to for that, and who is providing that that technical assistance?
Okay. Yes, in the blue shirt.
Hi, I'm John Barrazzo from USAID, and I am not responding to Anne's challenge. But I do have a comment and a question, and it actually builds nicely on the previous comment. The issue of pooling versus essentially versus alignment in other ways of all actions at country level around an investment case, is very critical to the way USAID operates, where most of our actual resources are actually at the country level and programmed on a bilateral basis. And nevertheless, the role is not so much necessarily the importance of actually implementing service delivery through NGOs, but rather providing effective technical assistance. So the comment is that role, I think, is very much aligned with the view that Sean was promoting, that we have alignment of all the different actors and what they might do. But my question is actually very much aligned with the previous question. From the perspective of the country, this is for the High Representative, how do you see the alignment of these technical assistance efforts with the available funding that comes through our central mechanism? And also, apart from that, the broader issue of advocacy for domestic resource mobilization. There are a number of external and internal partners advocating for domestic resource mobilization. How do you use external technical assistance to help sort out those various demands? Thanks.
Great. Okay, back here.
Thank you. I'm Margareta Burdick from International Rescue Committee. My question is specifically on the progress of the GFF in fragile countries and how it differs in how you plan for, how you fund, how you approach it. Thank you.
Okay, let's take one more because this is our last. Yeah, that's okay. Go ahead, Jessie. Sorry.
Hi, I'm Aubrey Cody with Global Health Visions. My colleague, Susanna Hurd, is the interim coordinator for the Civil Society Coordination Group, which is hosted by PMNCH, and she's currently in Malawi at an orientation weekend for Malawian CSOs. And my question was specifically around understanding what we've learned about civil society engagement. We know and appreciate that the GFF is always learning and refining as it goes. What have we learned in the first 16 countries, and what really needs to be improved and applied in the 10 countries that were announced last fall and then going forward? Thank you.
Okay, last one in the middle. Sorry. Right here.
Hi, Claire from Institute of Development Studies. So I thought the approach to sort of regional mapping was really interesting, given we know now that poverty is experienced spatially and that some people who live in really remote rural areas just don't have access to basic primary health care. So how do you go about sort of identifying those areas and looking at those sort of vulnerable, hardest to reach groups such as indigenous populations? And what's the sort of breakdown between the global financing facility and the country?
Okay, so another good set of questions. Let's start with you, Sharif. So the questions was what are your needs for technical assistance, and where are you getting it now? And the question from our USAID colleague about is TA being aligned? If that is TA being aligned to the objectives of the GFF work, or what reflections do you have on that? And anything else that you'd like to add as a final comment?
Bien.
Fine.
Oui, les besoins En fait, elle a posé la question par rapport aux besoins
Yes,
techniques
the
ou
lady
aux
asked
besoins de
about
financement,
technical
sur quoi
assistance
nous donnons la
and
priorité.
financial
Mais je
needs
pense que
and where our priorities
tous les
lie.
deux sont
I
des
think that
besoins
both things are
actuels parce que
current needs
en
because when it comes
termes d'expertise ou de
to
technicité,
expertise or
on ne peut
technical
pas avoir la
assistance,
prétention
we can't
d'avoir
pretend to
tout le nécessaire.
have
Donc,
everything we
chaque
need.
fois
So
qu'il
each
y a
time
une plus-value
there's
à ce niveau,
of added
il est à
value at
prendre.
that
Et
level,
c'est la
we
même
should
chose
take that opportunity. And
au
this
niveau des
is
besoins de financement.
true when it comes to
Nos
funding and
pays ont
needs
cette
also. Our
spécificité
countries
d'avoir
are characterized
une multitude de
by
priorités. À la
having
limite,
many
tout est
priorities,
prioritaire.
and in a way,
Et
everything's a priority.
il faut faire parfois des
And
choix
so sometimes we have to make
difficiles, des
difficult
choix à la limite
choices,
même douloureux,
choices which are
mais l'un dans
painful,
l'autre,
but
nous faisons le choix
we
à la fois de
do make
l'éducation,
a
de la formation
choice
et celle de
when
la
it
santé
comes
dans
to
lesquelles
education and training and health,
nous nous
because
investissons
we want
d'abord avec nos moyens,
to
comme je vous l'ai dit
invest
là,
first with our own
ce que nous avons
resources,
fait
as I
entre
said,
2016
what we
jusqu'à
did
aujourd'hui,
between,
mais nous avons financé
since 2016. Well, we've
déjà sur notre propre budget,
funded
quand même,
this out of our own
au-delà
budget,
de 100 millions de dollars,
more
tout ce qui
than
concernait quand
$100
même
million
les soins pour les enfants,
when it comes
pour les
to
femmes, pour
child
la recherche sur le
healthcare,
cancer,
care
etc.
for
Donc ça veut dire
healthcare for
que
women, for cancer research,
nous
etc.
nous
That
engageons
means that we
avec
have
nos
made a
propres
commitment
ressources.
with
Mais
our
il est
own
évident que
resources,
ces
but
ressources
obviously
ne suffisent pas.
these resources are
Donc,
insufficient.
nous avons
And so
tout intérêt justement
it is in our interest
à faire appel à
to
des ressources internationales, à des appuis internationaux.
obtain
Il est
international
évident aussi
resources,
que,
international
c'est un
support.
point de vue personnel, je pense
Obviously, and
que
I'm
différents
talking
États,
here personally,
au
but
regard
it's true that
des
various
richesses que ces pays-là ont, on
governments,
pourrait éventuellement
various nations,
indexer
because of their resources,
la
well,
question de la santé ou celle de l'éducation
they could
sur
they
un
could
certain nombre
index
de
health
richesses
or
comme l'or, comme le
education
coton, etc.
on
pour
certain
produire,
wealth
on,
like
on peut créer des
gold,
taxes
cotton, etc. You
pour
could
financer tout
create a
ça. Mais
tax
dans tous
to
les
fund
cas,
all of this
seul
healthcare, but
il va être difficile, totalement difficile, pour ne
but
pas dire
it's going to
impossible,
be difficult, even
pour nos budgets
impossible,
nationaux,
in view
de
of our
pouvoir
national
apporter une
budgets,
réponse
to be
satisfaisante
able
à ces
to
questions-là
give,
si nous n'avons
to solve these
une
issues in a
contribution
satisfactory way if we
extérieure en
don't get
termes aussi bien en
external
termes financiers
support
qu'en termes
both
d'expertise. Et
financial
d'ailleurs,
support and expertise.
sur cette expérience
And
que
when
nous
it
avons
comes
vécue sur
to
la
the
gratuité de la santé
experience
pour
we
les enfants
had about free healthcare
et pour les
for
femmes,
children and
mais nous
women,
nous sommes rendus
well,
compte
we
à un moment donné, parce que
realized
nous sommes un
at
pays
some
enclavé,
point, because we are a
donc
landlocked
nous
country,
avons au
and
moins 5 à 6
so
pays
we have 5,
avec
6
lesquels nous
countries
avons une frontière
with
commune,
which we
mais
share
les
a
gens
common
traversaient la
border.
frontière
Well,
des
people
autres
were
pays pour
crossing the
venir se faire
border
soigner
from the other
chez nous,
country to
alors que nous
come to our
n'avions pas
country to
intégré
get
ça
healthcare.
au départ dans
And
notre
we
budget.
had not
Donc,
included that
vous vous
in
retrouvez
our budget.
avec
So all of a sudden,
une autre approche à redéfinir. Parce que
there
vous
you
avez
have
des
to
gens qui
redefine your
viennent du
approach,
Niger,
because
vous
you
avez des
have
gens qui viennent du
come
Mali, vous
people
avez des gens qui
coming
viennent
from
du Bénin,
Niger,
que vous
from
n'avez pas
Mali,
pris en
from
compte
Benin,
quand vous
and you
définissez
did not take
votre
them into
approche.
consideration
Et
when
ils ne
you
peuvent pas non plus
define
venir et vous allez
your
dire que vous n'allez
approach.
pas les
And
soigner.
they come,
Donc ça veut
and
dire que
you can't say you're not going to give
il
them
faut
health
même
care. So
essayer d'avoir une approche à la limite sous-régionale ou en tout cas entre un certain nombre de pays ayant les mêmes réalités pour pouvoir agir ensemble. Parce que à un moment donné ou l'autre, vos données sont totalement faussées.
because at one point then your data
Voilà.
is completely wrong because of this.
Je pense que j'ai répondu
So I think I
à
answered
l'essentiel des questions.
the questions.
Thank you. So let's ask our other, I think each of you could say something about what have we learned on civil society engagement, either through direct experience or in speaking with colleagues. And the issue of providing the needed technical assistance, first, how do those demands get expressed by country counterparts? Is it being organized in some way? How are you working with USAID on that?
You want me to start?
I think
yeah,
so.
Yeah. First of all, what we of course learned from our experience in the first 3 years is how essential civil society voices are and civil society engagement, both in terms of accountability, but also as a voice for groups that needs attention. Because civil society is such an important player, and as has been pointed out before, they are part of the GFF partnership, we really have also really recognized the need to build capacity, since we are talking about financing here and financial flows. Those can be quite difficult areas of work, so really supporting and building capacity among civil societies at national and subnational level to play that role. I want to re-emphasize that the GFF is a country-driven partnership. That's why it's not, even if you have, you can grow technical expertise in different capitals, in Washington, Geneva, New York, etc. That's not going to be the way we want to work. Luke sits over there, who leads our country operations. We're really supporting countries to get the best technical advice, whether it's from the UN, the H6, international NGOs, local NGOs, CSOs, private sector. And we are trying to structure that so that you have a technical assistant matrix. You have your investment case, and you don't just map financial resources, but you also help in a more structured way to map the technical assistance. That we think is essential. On the financing, I also want to re-emphasize that the way complementary financing comes into the GFFs to the country's investment case, and there is a table with many, many bilateral and multilateral donors listed per country. It could be parallel financing, it can be co-financing with a legal agreement and some kind of memorandum of understanding. It could be through a single trust fund or a multilateral trust fund. Here is really where you have to be innovative and creative. Each bilateral partner has its different ways of doing business, and how can we just ensure, with the interest in aligning, how can we really bring in our partners using the complementary financing modality that works best for that partner. Clearly, one of the experiences we have now gained from the first 3 years is if countries direct the resources to those most in need, you end up working in fragile areas. And that's a very valuable experience to know, for example, that if you contract, if you purchase for performance, and the performance you are interested in is really outcomes, and not whether there are drugs or vaccines in place, but actually are more mothers seeking care when they need to deliver their baby. If we have those kind of outcome measures, we are really excited about the fact that you can make a difference in the most difficult circumstances if you match purchasing with performance with good accountability mechanisms, really strict, solid, setting up those governance accountability mechanisms. And that is exciting. And I think one reason we want to replenish and have more ability using trust fund to catalyze investments is because we want to support more fragile areas, because that's what the world is increasingly looking like in some parts. So that's why we have valued the partnership with Burkina Faso, because there are many countries in the Sahel who would like to join the GFF and who are not yet part of that, and where they are facing both, security challenges as well as fragility. So a very important part of the world that we think that really the emphasis and the focus needs to be in.
Yeah, I think there are a cluster of questions around civil society organizations, and as I was reflecting, I think one can use that term as an umbrella term for organizations that are vastly different and do vastly different functions. And I think it's important to perhaps deconflate some of that. And I think there are probably 3 essential roles that we often look at for civil society organizations. One is around advocacy. One is around a technical assistance partner. And then one role is then direct service provision, which can take different forms of, for example, faith-based health service delivery or in emergency settings, et cetera. And I was going to speak perhaps, and so I think understanding what are the different roles that are required, and then what are the different roles and capacities of civil society organizations to match them up is important. I do think that particularly on the advocacy side, particularly when it's helping educate parliamentarians, help educate other members of government. I mean, usually the Ministry of Health is the most fundamental ally, but ministers of health as public servants are constrained in terms of what they can do to actually communicate to budget committees, finance committees, and parliament. And local civil society particularly can be an incredibly influential voice in making the case of why these sorts of investments are so important, holding the parliamentarians accountable for the purse strings, but then also bringing, well, this is what the actual performance has been. I wanted to come then a bit more to the technical assistance role, and I do think as donors who are often funding civil society organizations that provide those sorts of technical assistance functions, I think we need to be careful about what are the incentives we're creating and how do we actually make sure we're not creating incentives for unintended negative consequences. And I think the trajectory, unfortunately, as any organization, the money that flows through you is incredibly important because that's what generates your overhead, keeps your lights on, et cetera. And in most any structure, your incentive is to grow your budget bigger. But I would argue if you're really focused on technical assistance, over time, you actually have less money transiting through you, and more of it's actually transiting through government infrastructures. And you're actually focused much more on that added value of being real technical experts in a given domain where the government, you have a partnership with the government. And so, but often, but then being explicit that we're not holding you necessarily directly accountable for that outcome of how many children were breastfed immediately and how many women delivered, but what is the quality of technical assistance you're providing to the government? How are you actually building those human resources? So the problem is, I think, selling that back to the taxpayers is it's more distal to those direct inputs. And then also that means that the structure of a budget of a grant to a civil society organization in this case is heavily loaded towards personnel because you're actually only paying for the technical assistance and direct program support. In an ideal scenario, more of that's being channeled actually through the government. So I think we need to be, if that's truly the role we want civil society organizations to play, we need to be very careful about how we are lining up that they're actually funding them to do that and creating incentives for them to do that well.
Yes. Okay, that sounds good. Anne.
I fully support what Mariam and Sean have said. I think trying not to duplicate. I think I would add I would define within the advocacy function the accountability and the voice of the community, which I think is implicit in what you said, but just to be explicit about it. I would also add that civil society can also play an important role on the research side and generating the evidence, and in particular generating evidence around what may otherwise be neglected issues. I think just one other additional thing that I would like to say is that I think a key role for civil society is, and this comes from being the voice, ideally the voice of the community, the voice of the end users, is around a focus on quality as well as coverage. And we do see that reflected in a number of the investment cases, a really strong focus on quality, and I think that's a critical role for civil society. So a lot more to be said, but I can see we're at or over time, so I'll let it go for that.
So we finished, and Sid, I guess that we as CGD are also part of civil society, and I think we do see our role more in the evidence analysis and accountability space, and that's why we're really pleased to have been able to host Mariam and this distinguished panel to talk about the GFF results. Mariam, do you have any final comments you'd like to make?
No, I think you ended on a very nice note here. It really is about bringing the value add of different partners, the accountability, the technical expertise, and really to think catalytic about the future and think differently about how we do business and take some risks there in order to support countries in the lead. So thank you.
Exactly. Thanks to all of you, and thank you to the audience for coming on a rainy day. Thank you.